Well, I'm Dr. Jim Rosso, the editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, and I'm here with two colleagues. Diego and Graham were involved with the publication of an article in the April 2026 JCAD entitled Severe Nail Psoriasis and Early Psoriatic Arthritis, Illustrative Cases Confirming that Severity of Disease is not solely dependent on the extent of body surface area. And this article brings forth a lot of information. There's a lot of basic information on the nail unit and the anatomy of the nail, which is not only the nail plate, which is what we think of, and it goes through some of that background to give the reader of the article a lot of information about nails to correlate with what we see in psoriatic arthritis. But the two cases are very illustrative of the significance of psoriatic arthritis and how it can impact on the severity of disease, which doesn't have to correlate at all with the body surface area of involvement on the skin. So Diego presented one of the two cases. And Diego, I thought this was a fascinating case because it was 63-year-old white female who had a history of, quote, brittle nails for 10 years. How many people come in with these long-standing histories of problems on the nails, had been through multiple rounds of topical and oral antifungals for onychomycosis, which she didn't have. And you actually looked further for that to make sure. You did a nail biopsy to confirm
Mhm.
that the patient had psoriasis, which I'm going to ask you to elaborate on. But why don't you bring forward what you think are some of the really important teaching points? Because if you look at this case, when the patient comes in, it it has the appearance is so severe, but that doesn't necessarily predict to us what's actually going to happen with the treatment. So, Diego, the floor is yours.
Yeah, certainly. Thanks so much, Dr. D. I mean, this case was particularly interesting because it is the worst case I've ever seen quite like this, where the nails were so thick in the nail plates that it almost looked like a pachyonychia, genodermatosis type patient, and she couldn't even use her hands. Yes, the hands were stiff and they hurt as well, but physically saying the nails would get caught on buttons or cups and typing, like she was functionally disabled, which is fascinating to think about that, not just by pain, but by physically the size and kind of protrusion of the nails, and also so thick and hyperkeratotic that I really even second guess myself. Maybe this is a fungus. I mean, I've seen fungus on toenails sometimes look this bad and this hyperkeratotic, and but then she had been treated with long courses of oral fluconazole, oral itraconazole, oral terbinafine, topicals, and so at that point, I was fairly confident that it was going to be psoriasis, but I did do the nail unit biopsy to make sure it wasn't lichen planus or some other kind of zebra condition.
So the fact that the toenails were unaffected would have made it even more unusual, as far as fungal, having only fingernail, all the 10 fingernails involved. So as far as the biopsy, because I think there's a lot of confusion, or maybe a lot of clinicians in dermatology don't do nail biopsies. You had to get back into the full longitudinal involvement into the matrix to see what was going on.
Yeah, so I usually do it by doing a distal digital block, and then essentially drawing a small wedge or ellipse that includes at least the distal portion of the matrix, and then take it down to the bed of the nail. Yeah.
And not going too wide, because then you're going to create a permanent loss of that matrix, and that nail's not going to grow, and you're going to have a big separation of the nail. It'll look like lichen planus then or something. You created it, right? So one of the things that I thought was interesting was that this patient really didn't have any cutaneous psoriasis when you saw them. They had some
Mhm.
joint stiffness, some pain of the joints, not only the fingers being tender, because as you said, they couldn't even shake hands with people or really function at all. And hitting that was going to make the fingers uncomfortable and painful, but the joints were involved. So you had psoriatic arthritis, really no body surface area of cutaneous disease, but you had a patient that was really immobilized psychologically and physically. So, How do you equate this as far as the severity of the disease, calling it severe psoriasis?
Yeah. So, from my perspective, it was about as severe as it gets in terms of, the dysfunction and the interference with this person's life, physical and emotional health. And so you're right, there was no cutaneous findings at the time, but I think my global assessment, if you will, right, was of severe psoriasis, and that's what helped me in terms of getting, approval for bimekizumab in this case, as well as writing down all of the factors to which you described, the impacts on the patient.
The severity we got hung up on early on by saying, oh, you had it's based on body surface area,
Mhm.
but there are certainly a lot of other factors that are involved. And knowing that nail psoriasis has a very high correlation with psoriatic arthritis. It could be seen without psoriatic arthritis, but patients with nail psoriasis will very commonly, 90% or more of them, have psoriatic arthritis, but it might be subtle in the beginning even if you weren't look for it. She said, my fingers hurt. And you're thinking, well, of course, you're banging them into everything. You took the time to look, and the stiffness was very, very helpful. So let's talk about the therapy. So you're starting the therapy, and we certainly have the advances of biologics for psoriasis that have really helped improve the response of nail disease. But specifically, what we've seen with anti-IL-17 agents, and now with bimekizumab being two fractions of the IL-17 A and F, the rapidity of response not necessarily in all cases, it depends on how much nail involvement you have and the depth of it. But you're going to see faster response in many of these patients. So can you describe what you saw in this case?
Yeah. So, to your point, I always will bring up to a patient with nail disease, especially, that it takes a while for the nails to grow out, right? That nail plate has already been, the nail matrix was affected while that nail plate was made. And so new nail has to essentially be constructed, regardless of what the drug's doing in order to be able to see that clinical benefit. So I always
Yeah.
kind of lay that framework, but seeing the rapid results that I had seen in practice already with the cutaneous manifestations of psoriasis and arthritis in my IL-17 patients, and certainly bimekizumab, I was excited to see how fast the patient could improve. So I gave her that hope, but also with a little bit of reservation that it could take a while. And I mean, within 4 weeks after the first shot, she noted a major improvement in the way the nails felt, right, in terms of tenderness, stiffness, a lot of these symptoms that were, seemed to be arthritis, but also maybe a little bit vague because she would report that they would, of course, hurt a lot when she would touch things or accidentally touch things with the nail plate. Not too much change yet at that time with the actual nail plate itself, but then within a couple of months, it was fantastic. I mean, she had at least a 50% improvement, if not more, and
Yeah.
within yeah within 3 to 4 months, it was nearly all gone.
Yeah, you can see that in the photograph. So it sounds to me like the teaching point is the way the nails look could mislead you. The thickness, you have hyperkeratosis of the nail bed, the nail plate. You're thinking, how is this ever going to improve? Don't be fooled by that. Recognize that it's all related to where the underlying inflammation
Mhm.
is. And these biologic therapies, and in my experience, the IL-17 agents really offer the best advantage. And I've seen great responses with bimekizumab, as you mentioned. Graham Litchman presented a 56-year-old white female. She didn't really have any significant past medical history other than a very long process of having chronic fingernail changes and periungual inflammation, no toenail involvement, and diagnosed previously as eczema, chronic paronychia, onychomycosis. This is before she saw you. Uh, Oral and topical antifungal agents, a lot of psychological stress, avoiding contact with the outside world, not going to salons to have her nails done, which she loved doing, and then saw a rheumatologist who diagnosed her with rheumatoid arthritis and onychomycosis. So she went on rounds of oral antifungals for a prolonged period of time. Guess what? Her nails never got better. What I think was great about what you observed and noted was, yes, she had the obvious appearance of all her fingernails being involved. And there's that shock value when you see the nails of, how is this ever going to get better? the initial looking at the nails, and the pictures definitely show that, right? But she had joint stiffness, right? And also involvement of some other joints. So there's not only the nail involvement with really very little to no cutaneous psoriasis, but also psoriatic arthritis.
What I often find is that when I hear someone say, "Hey, I've had this nail fungus forever, and we've tried X, Y, and Z, and it's just not getting clear," immediately my ears are perking up. I'm thinking, what else could there be? And so I start asking those qualifying questions that you and I and Diego, all talked about when we first presented these cases. Where, are you having any issues with your joints? Are you having any other skin involvement? Are you seeing rashes? And once you start walking down that line, oftentimes you will find what we found, like in this patient. She had other things going on.
The joint stiffness and the fact that she had fingers, but also wrists and lower back and sacroiliac area
Hmm.
stiffness that got better, right? It got better with movement, right? At
Hmm.
rest, it was worse. And that's a big pickup for psoriatic arthritis. So now you have someone that has really essentially zero, maybe very little cutaneous involvement, but we're calling it severe, right? It's
Hmm.
severe on the basis of the nails being involved. And what's interesting about her case, which we'll get to, you can see a lot of the proximal nail is not affected. You can see the lunula, but you
Hmm.
see all this distal involvement that's horrific looking to the eye, right?
Hmm.
And people, people thinking this is not going to change. But the we're calling it severe with really not a lot of cutaneous involvement based on the nails, based on the psoriatic arthritis, and the psychosocial aspect of how it affected this woman. So you now have to justify treating it, in which case bimekizumab was used, an excellent choice, obviously, and she responded very, very quickly. How did you justify that to get approval for that treatment? You follow? Because they're
Yeah.
going to come back and say she doesn't have any body surface area on her skin,
Yeah.
right?
Jim, honestly, I think not only is this a great question, but this actually may be the question, right? Because at the end of the day, we're trying to get our patients better, but if they don't fit the profile, we can't get them the medication. And I think the most important thing to do, at least what I've found here in Vegas, is making sure that you're documenting exactly what's happening with their life. How is it affecting them? It's kind of like when you see these clinical trials and we see these PROs, right? These patient reported outcomes. How is their life actually being affected? Does it have to really do with the BSA, or does it have to do the fact that they can't interact in their community? They're losing time at work. They're not doing the social things that bring them happiness, which is now causing them some significant clinical depression. These are the things that we need to use to not only qualify them, but we have to put them in the chart. If it's not
Right.
documented, it didn't exist.
And she has psoriatic arthritis, which could easily be missed if you're not looking at visibly swollen joints, right?
Correct.
Where they just have the stiffness and maybe tenderness if you're palpating those joints. So that gets missed a lot, unfortunately, I think, in clinical practice. So you got to start it on bimekizumab, right? I think we do have very good information on bimekizumab for psoriasis, and we have comparative data to other drugs, not necessarily for nails specifically, but we have good data for nails. And she had a tremendously quick response. Now, in looking at her nails as compared to Diego's case, which is a little bit harder to tell, what's going on proximally, the magnitude of inflammation, but her, she's pretty much clear on the proximal half of her nail plate. So that's a very good sign. But her response was so rapid.
Right. So you got to make sure you're asking those questions like, what do you do for work? What are your hobbies? What is most important to you in terms of what you're showing me today? You'll be actually quite surprised to learn what they say. And when you ask those questions and then retrieve those answers, you now can help lead down a very specific path that ultimately will save you time because you're not describing all the different medications that possibly exist. You kind of already have in your head where you're going to go. And it makes it for a much smoother and more productive encounter. So that's definitely tip number one. Number two is making sure that you are documenting not just what you see on the patient, but what the patient is telling you. So, in terms of how it affects their life, try to put some sort of objective score to that. So, whether it's itch, you can use any itch score you like. The common one is you can use the NRS, you can just use a standard 0 through 10, which I think is an 11-point scale that almost everyone uses, right? That's important to put down if someone's having an itchy process, if they're not sleeping, if they're not engaging in intimate activities, if they're being affected at work or with their personal relationships, that needs to be in there. So you have both objective and subjective.
And the pain and joint stiffness, make sure you emphasize that it gets better with movement because that
Yes.
points to the psoriatic arthritis as right, right,
100%. Yeah, I
right.
agree.
So Diego, any other teaching points from this case or even from Dr. Litchman's case? Because you saw the case that he presented and you were involved in that publication.
Certainly, yeah. His case was all remarkably impressive, similar to mine in the sense of, how the severity of the nails for that patient. But I think the commonality is this delay in diagnosis when it comes to the nails, and particularly if it's, primary nail psoriasis versus the cutaneous form, where yes, the nails can look yellowish or thickened, and it harkens back to onychomycosis, and people develop this anchoring biases on like that's what it has to be. And that's actually that's the commonality, but not the problem. I'd say it's okay to have your clinical opinion when you see a case and say, I think this is what it is, put your nickel down. It's just once it's not responding to therapy as you thought, then I think we all have that responsibility as clinicians to go back to the drawing board, to think outside the box, think, okay, what are mimics that I could be missing, right? Instead of treating people for 6 months, a year, over a year sometimes, without going back and second guessing that diagnosis.
And really the importance of recognizing, standing by you grading the severity of disease, not only on
Yes,
the
that too.
body surface area of cutaneous involvement, but what is happening with the patient. The psoriatic arthritis itself puts it in a higher class. Patients can have permanent joint destruction if you let it go too long. The symptomatology, but the psychosocial distress. It'd be
Hmm.
hard for anyone to look at this and think that if they had it or a loved one had it, that they'd be okay with it. Oh, it doesn't bother me very much.
Right.
We'd all be significantly distressed with it psychologically as well as physically. So, Diego and Graham, I want to thank you very much for assisting with this. The article was great. We've gotten a lot of great feedback on it. And being an associate editor, we know we're going to have a lot of more great articles that you're participating with. So, thanks again.
Thank you so much for having me, Jim. I appreciate it.
Thank you, my friends. An absolute pleasure. Happy to share this out there.